Hello, everyone. Thank you for having me. I want you to imagine that it's 1816 and you are René Laennec, the French physician who just invented the stethoscope, a tool that will end up revolutionizing the whole of medicine. Now imagine if the stethoscope and all the groundbreaking research and benefits to clinical care that it will enable was shared with only half of the medical world. If that had happened back then, what would healthcare look like today? Today, I'm going to be speaking about why healthcare AI communities need to pay more attention to primary care, the delivery platform responsible for 52% of all healthcare in the US, yet at risk of being left behind in the AI revolution, and how we might address that by advancing a national strategy for implementing AI and machine learning in primary care. Here are my disclosures. I collaborate with organizations through grants and sponsored research agreements that are administered by Stanford University. Neither I nor members of my family have any financial interest in these organizations. Also, I am currently a fellow at the National Academy of Medicine. The opinions I express are solely my own and do not represent the views or opinions of the National Academies. At the end of this session today, you will be able to, 1, explain the barriers preventing primary care from playing a larger role in healthcare AI research and implementation. 2, describe the recipe for a national strategy to advance primary care AI and machine learning. And 3, identify some contemporary examples of primary care AI innovations. As a heads up, there are 4 key takeaway slides, which are tagged with the label shown here. So let's begin. By every measure, whether it's in funding, startups, public awareness, research publications, or FDA approvals, AI and machine learning in healthcare is accelerating at a breathtaking pace. Global private funding for healthcare AI continues to break records, propelled largely by companies raising mega rounds greater than $100 million. Healthcare AI companies had already raised $8.5 billion in 2021 by Q3, surpassing 2020's record by 29%, making 2021 easily the strongest year yet for healthcare AI. The US continues to lead in global funding for healthcare AI, representing 2/3 of all investments, with an estimated $7 to $8 billion total in 2021. There are now approximately 2,000 AI companies in the US, many of which are dedicated to healthcare. News mentions of AI and machine learning in healthcare continue to soar, and public awareness of AI and its applications in healthcare are at an all-time high. The US government is also paying attention to the rise of AI. The number of mentions of AI in congressional records has skyrocketed in the last 5 years. Government funding for AI has also boomed. Federal departments and agencies spent a combined $1.8 billion on AI-related contracts in 2020. And in fact, AI spending in 2020 was more than 6 times higher than what it was in 2015. There's no question that the rapid growth of healthcare AI is powered by a renaissance in AI research and development spanning industry, academia, government, and healthcare. But if you take a closer look at who is doing the research, who the research is benefiting, and who is getting funded, you quickly realize that primary care, despite being the largest care delivery platform responsible for 52% of all visits in the US, is being left behind. This has huge implications for the type of impact AI and machine learning will have on patients, clinicians, health systems, and our society in the future. First, let's take a look at what research is being done and who's doing them. Globally, the total number of AI and machine learning publications grew by nearly 12 times between 2000 and 2019. Over the same period, the percentage of peer-reviewed publications in AI increased from 0.82% of all publications in 2000 to 3.8% in 2019. a clear reflection of the growing importance of the field. Notably, the majority of AI research is currently being done by corporations. This is followed by government, coming in second, and medical institutions trailing significantly behind. In fact, publications affiliated with medical centers account for only 11% of all peer-reviewed AI publications in the US, and only 14% of the publications includes at least one primary care author. So although AI research is accelerating, and AI publications are flourishing, primary care represents only a tiny fraction of that effort. Perhaps not surprisingly, of the 79 AI medical devices and algorithms approved by the FDA so far, only 2 or 3% are intended for primary care. Radiology accounts for almost half of all FDA-approved AI tools at 49%, followed by cardiology at 20%, and neurology at 8%. What about public sector funding for AI? Only a small fraction of government spending on AI is going to healthcare, with the overwhelming majority going to defense. Department of Defense's total contract spending on AI from 2001 to 2020 was more than what was spent by the other 44 departments and agencies combined. By contrast, the Department of Health and Human Services and the Department of Veterans Affairs, the two agencies most directly responsible for the nation's healthcare, have relatively little to spend on AI. In fact, studies have shown that only 1% of all federally funded research goes to primary care. So, primary care, despite being the largest US care delivery platform, is at real risk of being left behind in the healthcare AI revolution. Inpatient hospital care, which has received the most attention and funding in terms of research and development, accounts for only 4% of all care delivered. By contrast, primary care accounts for 52% of all care delivered, but only 14% of AI publications involve primary care, only 3% of FDA-approved AI is intended for primary care, and only 1% of federal funding goes to primary care. I believe that this must change. With more than 500 million visits per year in the US, more than all other specialties combined, primary care is where the power, opportunity, and the future of AI are most likely to be realized in the broadest and most ambitious scale. After all, primary care clinicians represent the single largest group of AI end users among healthcare professionals. Therefore, they have the most to gain, as well as the most to lose in the coming era of innovation. This is as much a call for healthcare AI communities to pay more attention to primary care as it is for primary care communities to start engaging in AI research and implementation. So, what needs to be done? First, we need more attention to primary care by AI research communities with reciprocal engagement from primary care. Second, we need more private and public funding for research, development, and implementation of AI for and by primary care. Third, we need significant infrastructure upgrades, both data and human, to support the above. But to truly unlock the promise of AI for the broadest population of patients, clinicians, and health systems, a national strategy for primary care AI research and implementation is needed. If more attention to primary care is the why, and more funding and infrastructure is the how, then we still need a what. And that is what the next section of my talk will focus on, a framework for a set of key objectives to realize this vision. To guide and foster the development of AI, countries around the world are establishing strategies and initiatives to coordinate governmental and intergovernmental efforts. Since Canada published the world's first national AI strategy in 2017, more than 30 other countries, including the US, have published similar documents. America's AI strategy is in a relatively early phase of maturity. In 2019, then President Trump signed an executive order called the American AI Initiative, which called out 5 key lines of effort: increasing AI research investment, enabling federal AI computing and data resources, setting AI technical standards, building the US AI workforce, and engaging with international allies. In 2021, these 5 objectives were codified into law as part of the National AI Initiative Act, which also established an office to coordinate cross-sectoral AI activities, expanded an interagency select committee on AI, and launched AI.gov, among other things. Although some of these efforts will impact AI applications in the healthcare sector, there remains no specific strategy dedicated to healthcare AI. So, what might we consider as a potential framework for a national strategy to advance primary care AI research and implementation? I believe that clues to such a framework can be found in the National Academy's Implementing High Quality Primary Care Consensus Study Report. This report, published in 2021, provided the blueprint for implementing a high-performing primary care foundation to the US healthcare system, as well as the critical functions of digital health to optimally support primary care. From a primary care perspective, digital health helps clinicians with collecting information, aggregating and analyzing information, and applying information to decision-making in clinical care. Multiple digital health tools can collect information from different sources. Once data is aggregated, systems are needed to analyze the information to make it usable by patients, families, and care teams. By translating these core functions of digital health into objectives for AI research and implementation, a potential framework starts to emerge. In this next section, I will describe each of these objectives and how they can help us advance primary care AI. Objective 1, automate data collection systems, is to get the data to train and power the AI. This will require a combination of data collection and reporting systems, including the next generation of truly interoperable EHRs, smart devices and wearables, AI scribes that can automate the capture of data from patient-clinician visits, and AI tools that can automate the capture of patient-clinician digital communications from patient portals. Research and development on these data collection systems will power a strategy for broader healthcare AI implementation nationally. Objective 2, optimize and federate data architecture, is to organize and crowdsource the data to train and power the AI. One of the biggest barriers to wider AI implementation is that small primary care clinics do not have enough data to train their own models, and large hospitals want to keep their data private and secure. One promising solution to this problem is federated learning, a new machine learning approach that enables organizations to collaborate on AI projects without sharing sensitive data, such as patient records. In federated learning, instead of data moving to a central place, machine learning models move to the data for training, then recombine to create a better global model. In other words, move the model, not the data. Such an approach for optimizing data architecture will power a strategy for broader dissemination of AI models, benefiting primary care systems that would otherwise not have access to these solutions. Objective 3, sense-make data for actionable care, is to use the AI to generate actionable insights for primary care. One example of an important primary care problem is to use AI and machine learning to predict avoidable emergency department visits and hospitalizations, which costs the US more than $100 billion each year. In fact, this problem was the focus of the 2021 AI Health Outcomes Challenge, which was operated by CMS, sponsored by Arnold Ventures, and partnered with the American Academy of Family Physicians to award an AI startup called ClosedLoop.ai to use AI to predict unplanned hospital and skilled nursing facility admissions using Medicare data. This project, by the way, is a promising model for future public-private medical industry collaborations on healthcare AI. Focusing on problems that matter to the health of populations will be an essential pillar of any strategy to advance AI research and implementation in primary care. Objective 4, Plan, Do, Study, Act implementations is to iteratively design and continuously improve the AI and its human workflows. When leaders are asked what factors most often derail AI implementations, the biggest issue cited is the challenge of integrating AI with existing human processes of care. Integration is difficult because current approaches separate the development of AI from the complex healthcare environments in which they are intended to function. One way to facilitate uptake of AI technology into human-driven care processes is to draw on methods and techniques from quality improvement. Plan, Do, Study, Act, or PDSA, is an iterative design and management method used in business and healthcare for the continuous improvement of processes and products that has been successfully used to implement healthcare AI in real-world clinical settings. As you PDSA implementations, you may encounter some of these common barriers to provider adoption of AI. For example, is the purpose of the AI aligned with the right values, priorities, and incentives? Is there the necessary data and human infrastructure to support the AI? Is there frictionless integration of the AI into workflows? Is there trust in the AI? Does it alleviate or worsen provider burnout? These are translational questions that can only be answered through implementation science, not data science. Any national strategy to advance primary care AI will need to focus as much on the implementation science of AI as it does on the data science. Objective 5, Remedy Unintended Consequences, is to identify and address the potential harms of the AI. Algorithmic bias, due to the lack of data representativeness, can make AI less effective for certain populations or even cause harm to subgroups due to inaccurate predictions. Even if you have a representative model for your system, it may perform poorly everywhere else, highlighting the issue of non-generalizability. How you deploy a model can also introduce inequities, amplifying existing discriminatory practices. Models can also be co-opted for dual use by scrupulous actors with profit-driven motivations. Lastly, AI may possibly replace or marginalize human labor, or subvert the patient-clinician relationships that lie at the heart of human healing. This figure shows the cascading effects of health inequities that manifest in the design and the use of AI. Real-world patterns of health inequality and discrimination result in the creation of discriminatory data, which leads to biased AI design and deployment practices, which exacerbates application injustices, which worsens real-world inequality and discrimination. Understanding and remedying these consequences needs to be a critical part of any strategy on AI research and implementation. So, if you take these 5 key objectives that I just described and combine them with the 3 lines of effort I outlined earlier: advocacy and education, funding and policy, and infrastructure upgrades, we end up with a recipe for a national strategy to advance primary care AI research and implementation. Realizing this vision will not be easy by any stretch of the imagination. It will most likely demand coordinated, cross-sectoral cooperation between government, industry, professional organizations, academia, and frontline primary care. But I believe, despite the challenge, that primary care can and should play a leading role in AI research and implementation. For this next segment of my presentation, I will go through some real-world examples of primary care AI innovations that my team and others at Stanford have been working on. The Stanford Healthcare AI Applied Research Team is a group of primary care physicians, implementation scientists, and quality improvement experts who are dedicated to applied research on AI in healthcare. We partner with many collaborators from industry, academia, and the nonprofit world to bring AI technologies from code to bedside to solve specific practical problems in healthcare. We're one of more than a dozen programs and centers at Stanford working on healthcare AI. Our team's special focus is on applied research and implementation with an emphasis on primary care and population health. Here are brief highlights into some of our projects. Dermatology and primary care. Skin conditions affect over 2 billion people and are a leading cause of morbidity globally. Primary care providers manage 70% of skin cases, but with lower diagnostic accuracy compared to dermatologists. Recent studies have shown that AI is non-inferior to dermatologists, and AI assistance improves PCP diagnosis for 1 in every 8 to 10 cases in simulated studies. What we're doing now is testing the AI's feasibility, acceptability, and performance in the real world, as well as its potential health equity implications. For example, whether the AI performs as well on patients with darker skin tones compared to those with lighter skin tones. Remote patient monitoring for chronic diseases. Hypertension and diabetes are among the leading causes of death globally. AI tools have been developed to organize big data from home BP and glucose monitors to generate actionable insights for remote patient monitoring programs. We are now testing an AI-enabled remote patient monitoring plus health coaching platform compared to usual care using a large, pragmatic randomized controlled trial within our network of primary care clinics. Predicting ED visits and hospitalizations. As mentioned earlier, avoidable ED visits and hospitalization are a serious source of human suffering and economic pain, costing the US over $100 billion per year. We have developed a suite of machine learning models that accurately predict these events for all causes and for a handful of high priority ambulatory care sensitive conditions, retrospectively. What we're doing now is testing these AI models prospectively and designing the human workflows around them to support a scalable, value-based care delivery program. Reimagining EHR in-baskets and patient messages. The burden of EHR in-basket work on clinicians has been known for some time, but it has only gotten a lot worse due to the pandemic, as work shifted from brick and mortar clinics into the digital space. PCPs are spending 1 to 2 hours per day outside of face-to-face patient care on the EHR in-basket, which is one of the driving forces behind clinician burnout. We are training and testing a machine learning model to read patient messages, predict the actions needed to resolve them, and automatically route them to the right team member or workflow for smarter, more efficient care. Improving advanced care planning. Most people say that they have wishes regarding their end-of-life care, yet only 1 in 3 US adults has an advanced care plan. Studies have shown that AI can accurately predict patient mortality. We have deployed and are now evaluating an AI-enabled team-based workflow to improve rates of advanced care planning conversations for both inpatients and outpatients. Lastly, automating clinical documentation. For every hour clinicians spend with patients, they spend another 2 hours at the EHR, mostly on charting, which is a well-known leading cause of burnout. AI scribes, designed to reduce documentation burden, are becoming increasingly popular and sophisticated. What we're doing now is testing their ability to document high complexity primary care encounters and exploring expanded use cases for the technology beyond documentation support. With that, I'd like to end with some closing thoughts by reflecting on a few big questions about the future of AI in primary care. Some have asked me, why do you need a separate strategy for primary care, as opposed to one that covers the whole of medicine? This is a tough question. A national AI strategy for all healthcare would, of course, be welcome. All of the key objectives that we discussed today are as applicable to other specialties as they are to primary care. There are a few reasons, though, for why I believe primary care deserves special focus and attention. The first is its sheer size and reach as the largest delivery platform responsible for more care than all other specialties combined. The second is that while specialty-specific AI tends to have an outsized emphasis on diagnostics, primary care AI tends to be more focused on the delivery and quality aspects of care, applied not only at the individual patient-clinician level, as is usually the case for specialty-specific AI, but also at the population level, which is unique to primary care. These distinguishing attributes of primary care carry implications for how a national strategy should be designed, what funding and policy levers should be used, and how implementation should be approached. Some also point out that early AI clinical decision support tools developed for primary care in the 1970s to the 1990s, such as Mycin for managing bacterial infections, or Athena for managing hypertension, failed to be integrated into routine care. So what lessons were learned and how are things different now? Well, one of the biggest problems back then was that the state of technologies for system integration. Early CVS tools existed as standalone systems that generated too much friction trying to integrate into human-driven clinical workflows. Another problem was a lack of alignment and incentives to drive adoption. Today, things are different, with better technologies for model integration, favorable alignment and incentives created by the transition from fee-for-service to value-based payments, and greater recognition for the role of implementation science supporting the data science. I believe that we are in a better position today to unlock the promise of AI than ever before. Finally, how do we realize this vision? What do we do next to advance a national AI strategy? Today, we propose the beginnings of a recipe. Now we need to get the chefs in the kitchen to make it a reality. This effort will likely require coordinated, cross-sectoral cooperation between government, industry, professional organizations, academia, and frontline primary care communities. From federal agencies, we need effective technology governance policies, streamlined approval processes, and enhanced public sector funding. From industry, we need their economic engine, data and computing resources, and expert AI workforce. From professional organizations, we need collective advocacy and clinical workforce engagement. From academia, we need thought leadership, education, and real-world clinical laboratories to enable the basic and translational research required to move the field forward. Together, I strongly believe that primary care can and should play a leading role in healthcare AI in support of patients, clinicians, and the health of the nation. Thank you so much for listening.